Well, good evening, everyone. I'm Scott Malaney with my partner in crime here, Dr. Bill Kose. Um, Thank you for joining us. As we have in the past, our goal tonight is to provide information. So please feel free to send us questions and comments. We have a number that we will be addressing here in a minute. Um, we're doing this on very short notice, and the reason is simple. About a month ago, Blanchard Valley had roughly 10 or 12 COVID patients in the hospital. As of last Friday, we had 28, I think the number was, maybe 29. By Monday, we were up to 51. Um, so the increase has been precipitous. And the sickness, if you will, of some of the people is very concerning. So um, lots of questions in the community, and we thought the best thing to do would be to try and answer the questions that you have. So thanks for tuning in. We will get to the questions in just a moment. I'm going to turn it over to Dr. Kose and let him kind of give you the broad background of where we find ourselves today, and then we'll get to your questions.
So as Scott said, we have seen a dramatic increase in the number of cases. And when we talk about the number that are in the hospital, that's really the tip of the iceberg. Those are only the ones that need to be admitted. We're seeing in the emergency room 40 to 50 individuals that may have COVID. Most of those are positive. Most of those are being sent home, and we can talk about treatments and things later. What that has done is it's put a tremendous stress on the healthcare system. One, follow-up if somebody goes home, but especially in the hospital, our workforce, the staff, that includes obviously frontline nursing, respiratory techs, anyone to be seeing patients, but even with our cleaning people, with maintenance, with dietary, all of those things have put, as I said, increased stress on the organization. Our beds are almost to full capacity. Yesterday we had 10 or so individuals waiting in the emergency room for a bed. We did end up transferring a couple because we have our pulmonologist helping at Wood County. That seemed like the safest, quickest, easiest thing to do for the patients. They were at near full capacity at the same time. Today, when I just visited the emergency room about 5, we've got 10 individuals waiting for beds. 6 of those are COVID patients. We have the beds, we have the capacity now because individuals have been discharged or are being discharged, but the general frame is we are clearly being stressed, being pushed about what's going on, and we're developing plans, which I think we'll be talking about too. What if it goes higher? We've got 50 patients in the hospital now with COVID. What if it goes up 10, 20 more? We have plans. We're trying to develop those.
Hey, Bill, let me ask you a quick question. So all of a sudden we have these patients that need to be in the hospital. What are the diagnoses? What are the physicians looking at to decide this person needs to be in the hospital?
And that has continued to be a work in progress as to when do we want to admit someone. So basically, we're looking at the individual themselves. Do they have risk factors, especially if they're elderly? There's some social component related to that. Are they going to be able to take care of themselves at home? Obviously, it's more difficult for church members to check on people, for neighbors, because if somebody is COVID positive. We're also under stress with the number of people that can be seen by home health. So all those things are taken into consideration. The basic thing is, what is your oxygen level? Are you keeping a level up high enough that you shouldn't get into problems? One of the concerns has been all along about COVID is this rapid deterioration. I don't think we've seen as much of that as we thought what we were going to back in April and May, but it's still a concern. So having individuals, if they're at high risk, if their oxygen level is borderline and we send someone home, we're trying to get them on pulse oximeters so they can measure their oxygen. If we don't feel comfortable with them, then they will be admitted. One of the other things we'll do is, if I have a certain oxygen level, before I'd go home, I'd get up and walk and see whether my level drops. And if it drops, that's an indicator well, the capacity of the lung to work with the infection's not good, and so we will in general admit them. And then there's individuals that you see, they just are sick. I mean, whatever they've got, they're not going to be able to take care of themselves, and they're going to need treatment with oxygen and with care and those kind of things.
What about, I know we've been seeing more patients on ventilators, and in situations where we're providing more levels of oxygen. What can you say about that?
Well, and it is concerning. One of the things that one of the intensivists told me is that he's afraid that individuals are waiting too long to come in before they get evaluated and either get started on treatment or educated as to what to do. So that is a concern. It may be part of the disease state too. The magnitude of the number of individuals that are sick are still unknown because we don't have enough rapid testing to be able to tell. So maybe there's a lot more people out there sick, and again, the tip of the iceberg is what we're seeing, the sickest of the sick, and they are getting admitted. But we thought for a while that we weren't going to see as many people on ventilators. That was, if you remember back in April, the concerns were PPE, protective devices, and ventilators. That's what the government was looking at. Are we going to have enough vents? Well, we had plenty of vents, and then we didn't seem to be using them as much. But as you point out, at least our experience here is we are seeing more, and we are also, the physicians are making attempts not to put people on respirators. It's been difficult. It's always difficult when someone goes on a ventilator to get them off. I mean, they're really sick. As you're on a ventilator, that's no picnic. I mean, we talked today, you're losing body mass, you're losing muscle mass, and we want people to be up and moving. But with that being said, we do seem to be seeing more. We're starting to see younger individuals that are on vents. We had a younger 20s individual admitted yesterday, and on rounds this morning, they were concerned she'd just been in overnight and that she might have to go on a ventilator. So it is a concern.
Well, she is on a ventilator now.
Yeah.
23 years old.
Yeah.
So, amateur doctor here, one of the things I would say to everyone, if you think you have a cold, if you think you have allergies, if you aren't feeling very well, now's a great time to make sure that you either talk to your doctor, come to the emergency department, and find out if you have COVID or not. One of the things we are definitely seeing, and Bill and I talked about this earlier today, people will wait a little while, assuming they have something else, and by the time they get diagnosed, they've got pneumonia on top of it. That's become a fairly common thing, and you can just imagine having to try and deal with pneumonia on top of COVID just complicates the care quite a bit.
Yeah, and one of the problems is from a physician standpoint is the pneumonia related to the COVID directly? Do I have COVID pneumonia, or do I have an infection on top of that? If you go back and look at the history of influenza, the pandemic of the 1917, 18, 19, what occurred, the feeling was, and we didn't even have antibiotics back only 100 years ago, was that a lot of people got influenza and then got staphylococcal infection on top of that, and then they died because of that. So as a physician, when I see someone and they have pneumonia, which is an infection of the lung picked up on an x-ray, we try to get a culture, we try to figure out what it is, but since it could be bacterial, then we will start them on antibiotics. And the sooner you get started on any treatment, commonsensical, that it's going to make a difference in how soon you're going to get over things. So back to your point, Scott, is we just need to see people quicker, and we've been working with our primary care physicians about what our protocols, what's the best thing to do, using best practices. We're in contact with Mayo. We've looked at keep up with the literature. We've got some really sharp intensivists here. We had a medical education program last week. A couple hundred people were on it about what are the things to look at to go get seen, what kind of things can we do to prevent things, what kind of medications and that sort of thing.
Before we move on, I meant to say this at the beginning. Bill and I both have our masks. We are 6 feet apart, and the reason we're not wearing them is to make sure you can understand us. So please know that we're sensitive to that, and were it not for that, we we would have our masks on.
Yeah, I think that's a good point, Scott. And you know, what I've been telling people, this is different than what we were seeing back in, let's say, May and June. Different because it's not that you can't trust anybody. Anybody can have this now. We still think 35 to 40% of people that have it are asymptomatic carriers. Now, I've been tested, Scott's been tested, we're not being tested every week. We don't have any symptoms, but would be completely understandable that I could give this to Scott tonight, just with what we are seeing out in the community. I'm gonna try not to.
Okay.
But for all of you, that is why it's so important to follow the standards that we've been talking about since this whole thing began.
So let's go to some of the questions that have come in so far. We have a couple of folks here that are helping us with that, and by the way, we appreciate you sending your questions in. Minnie, go ahead, or Jen, or whoever's reading.
Sure. One question that has come in through the comments. Many larger cities have plans to set up convention centers or larger spaces with beds and medical supplies for when their hospitals reach capacity. Is there a plan of any kind in place like this for our area? And also, for the patients that are being turned away from BBH, where are we sending them?
Let me take a crack at that one. The direct answer to the question right now is no. We had a plan in March to, in the language of Incident Command, stand up the Seagate Center in Toledo. We had the military setting up a bunch of cots and all of that. The reason we don't have that today is that we don't have personnel to take care of anyone there. And we had a long discussion today in our region, the Northwest Ohio region, about how are we going to help each other and what are we going to do depending on what the demand levels are. So Blanchard Valley, the good news, Blanchard Valley has a number of different stages depending on what the numbers are. We could, for instance, turn the ambulatory surgery center into a COVID hospital. We could turn operating rooms into small COVID sort of like pods. There are a number of options we have. In any event, we, along with everybody else in the country, really are having a hard time finding the personnel to care for those folks. So that's the quick answer to that one. The back end of the question, we've transferred, I think it's a total of 4 patients so far, and they all went to Bowling Green. And the reason for that's very simple. Bill already mentioned it. The intensivists that serve here also serve at Bowling Green. So we're able to stay very close touch with those doctors. We know we're very comfortable with the quality of the care they provide. We're very comfortable with the quality of care that Wood County provides in their advanced care units. So pretty comfortable with that. Our goal is to do as little of it as possible for obvious reasons. But that's a quick answer. Bill, anything to add?
No, I think I completely agree with that. When we've talked about it is, any of your history buffs, Napoleon and Hitler didn't do well going to Russia. You can't get ahead of your supply chain. And when you think about that, it wouldn't have been that hard to put people into a place, but you've got to have people, as Scott said, to be able to take care of it. You've got to be able to transport. We're trying to find all of the beds that we can here. Scott got arrangements for us to open up 12 more beds here in the hospital that have been allocated to something else. As we look at that, we've got to make sure we got electronic beds. We got to make sure we got information technology for our computer system. There has to be access by pharmacy to be able to document and to do things. And so having someone in a cot, if they didn't have any other place to go, makes sense, but it makes a lot more sense as much as we can control things here. And as Scott said, we've had 4 individuals. We would have found a place for them if we wouldn't have had a place. This just seemed to be the best for the patient to be transported, but we're going to figure out, and I wouldn't use the term we're going to turn people away. We're going to figure out how to take care of them. I can say as a community, we had a group meet today, meets every week. Public Health is running it. We approached the idea of having taking one of the hotels, and we could have people there. But again, somebody has to take care of them. They got to deliver food, laundry. I mean, all of those kind of things, and that's where it becomes logistically somewhat of a big problem.
By the way, real quickly, the other thing we've done is transfer some care down to Bluffton, our Bluffton hospital. We did some surgeries down there that were originally scheduled here. That worked out just fine. So we still have a lot of, I guess, arrows in our quiver in terms of dealing with whatever comes our way. Next.
Sure. Let's see. Will you start postponing elective surgeries?
Will you start postponing elective surgeries? The quick answer is if we have to. We have avoided that so far. We believe we have a plan based on what we know today that gets us through the week. We're trying very, very hard to act as normally as we possibly can. But if need be, if we wake up and 80% of our beds are taken by COVID patients, then yes, we would have to do something like that. Bill?
Yes, and I completely agree with Scott. It's fluid. It's something that we're going to be looking at on a day-by-day basis. So again, we try to approach that. What would a patient want to have done? And some of you may want to call back in. Well, what would you if you have an elective surgery? First, in general, elective surgeries mean you need to have the surgery. Maybe if I were having a total knee, okay, that's elective and I can put it off, or my cataract's not quite that bad. But for a lot of surgeries, those may be cancers, they may be bowel obstructions, they may be things that you need to have. They're elective because we're not taking you to from the emergency room to the OR at 2 a.m. We have an elective time that was set up. And we don't want to not do that. The two criteria that are important, and Scott's mentioned both of those, to make a decision of whether we can do elective surgery, or do we have bed capacity if you're going to need to stay in the hospital overnight. If you're going to go home, we've pretty much got it worked out that you could have, let's say, a cancerous breast biopsy done or whatever. If you can go home, we're going to be able to take care of those kinds of things. And the other is a workforce. We need enough nursing and all of the other individuals that I talked about to be able to take care of it. So day by day, we are looking at those two factors. We're also looking at who can be discharged, trying to keep track of what our capacity is going to be. And I think what as we've talked about it, and where I feel pretty comfortable, let's say I'm going to have an elective procedure done on Thursday. Well, Monday we would let you know it looks like we're still okay to do that test, but we may have to call you on Wednesday evening and say that we just don't have the capacity to be able to do that. And you may decide, along with your surgeon, well, maybe I want to wait. The problem is, and I'm trying to again look at it from a patient standpoint, I don't know when that next time is going to be. I fully expect, and I would be, I think of the majority what people think, this is not going to get better in the next 2 weeks. And if we don't all stay home from Thanksgiving, it may be even worse. With that being said, we are planning right now that the way we see this, that maybe we'll talk a little bit about vaccine, but this will go well into the spring, the possibilities of us being at a situation somewhat like we are right now.
In regards to contracting COVID, after recovery, are you immune?
I was anticipating this question, and I'm going to let Dr. Kose answer it, but I think, maybe to add to it a little bit, am I immune, and can I get it again, and am I safe to not wear a mask, all of that stuff.
So the answer is it looks like that you could still get it again, rather than being a continuation. It's a little longer answer, and so I'll try to cover that. So again, the question is, I got COVID. I was positive. This wasn't I thought I had COVID, but I had the positive antigen, antibody, whatever test that you had done, and now can I get it again? It looks like data would show that there are a few individuals that have gotten it the second time. Now, part of this, without getting into a lot of detail, is people can carry the antigen in their body and it may be dead and the test might pick it up. But these are new cases. It's been at least 3 months, probably 4 months before anyone has gotten that. But that is very concerning. It's going to be concerning about the vaccine. How long is it going to be effective for? And so what we are telling people is that you still ought to treat yourself as if you could get COVID and that you could give COVID. So you should still wear a mask, you should still social distance, and that that you ought to be washing your hands. If nothing else, that's good for you to protect you from giving someone else. So there's no guarantee. I would say if I've had COVID, had the symptoms, and I also had the positive test, that I would feel more comfortable about being able to work and to be able to do things, but I don't think there's a guarantee.
One of the things I remember from listening to Dr. Kose many months ago, he reminded us one day, or reminded, I guess, me, a coronavirus, a common cold is a coronavirus. And his comment was, we don't have a vaccine for a common cold. And the reason is because your antibodies don't last very long. You probably can go 3, maybe 4 months, and we all know you can get a cold again. Well, one of the questions that's still out there is that going to be true for this form of a coronavirus? I just think that's really an interesting question. I don't think we know the answer yet.
No, and I'm not enough of any kind of a virologist expert to talk about. The coronavirus is a very simple, it's not a real big as compared to HIV. And so does our immune system, and there may be someone on that knows much better than I do, when you have a more complex virus, that it develops better antibodies. And there's different kinds. We got T cells, we got B cells, different kind of lymphocytes that are the remembrance that go back and fight. Now there's been a lot of discussion about interferon, and I know I'm into the weeds, but this is such a complex new physiology that we really haven't been exposed to before. And it also may be that if I just got a mild case, I'm going to be more likely to get it the next time because I really didn't have the need. My body's just not going to make a lot of antibodies if it doesn't need to. And when it starts to do that, that's when we get into this problem of where people need steroids because of the overreaction of what occurs.
Right.
Somebody will sort that out someday, and hopefully we'll learn for the next pandemic we have.
Next question. If I'm at home with COVID, how can I test my oxygen level? Can an O2 monitor be purchased at a local pharmacy?
That is a very good question. Now, I'm going to smile first. I went out and I walked around one of the places, and I finally asked somebody, and I went, and it was, she showed me where, and what it would be is a pulse oximeter. Pulse oximeters can be purchased, but there weren't any. And then I found out that one of our nurses went out and bought every one she could find because we're giving them to people, and we're also put the pediatric ones in the room. I think if you go to most pharmacies, you can find one. What Dr. Ratnasamy has said, and I went out, I looked on Amazon Prime, and you can get ones that are FDA approved for about $20. I would advise you just go get one. The thing about it is that it just fits on your finger. It's easy to use, but you want to make sure that your finger gets warm. You put it on a cold finger and it may not work as well. It's pretty simple to use, and I would advise everyone to have one. That's just, and that's what we're trying to do from the emergency room, get enough that if we're sending people home that they can measure this, and that gives us that early indication that there may be some deterioration.
Again, without getting into a whole lot of detail, it is interesting, and you can read about this. There's a whole class of people that have COVID that have very low oxygen levels, below 90%, and don't even know it. And the problem is that your body is in some sort of battle. You're not oxygenating very well, but it's not obvious to you, and that can be really dangerous. So another way to know, obviously, if you've got your own pulse oximeter and it tells you you're at 88 or 86% or something, you better call your doctor and say, hey, I need, something's going on here.
That's a really good point. Is that one thing, if you do get one, test it while you're healthy, so you know one is it did you buy a good one? For $20, that's not it. That wouldn't have sounded like a lot of technology, but you could test it. So what I would do is test it on your spouse or one of your friends that you know is healthy, and the two of you, okay, it's reading what it ought to, it's consistent between the two. Then you have a baseline, so if you get what Scott said, so somebody's got chronic lung disease, they may have a low pulse ox to start with, and you know where you are, again, as a baseline, if it starts to deteriorate.
Good.
Next question. My children returned home from college. They just had an antigen test and both have antigens. They had tested positive in the fall for COVID. Can they still be carriers?
Okay, so I want to make sure I understand that. So they both had antigen, meaning they had an antigen test, the way we would understand this, it was positive earlier, and now they are coming home and they know they have had COVID. Yes.
It seems that they had COVID previously and they just had the antigen test.
Okay, so there, in general, if you knew you had COVID, there isn't any reason to get another antigen test. Now that's been not, I don't want to say controversial, because a lot of the businesses want somebody negative before they come back, and it's not a long answer. It really isn't that much helpful. Did they get over, so the answer I would give would be, did they get over the symptoms? Okay, they must have been tested. Well, they could have been tested as asymptomatic carriers. We don't think that somebody is going to be an asymptomatic carrier in general for more than 14 days. We start, if I got symptoms right now of COVID, went and had my test done, it was positive, I'm felt to be infected for about 10 more days. The cycle of the virus is about 14, 15 days. It takes 4 or 5 days, again, in general, before I get symptomatic, and another 10 days, I will not be positive. So getting another test really isn't effective, knowing that you've had one. And so if they've come home, it's been more than 10 days, they should be fine themselves.
So you don't, but the question kind of was, could they be a carrier? I
We
mean,
wouldn't-
what advice would you give? I think I've told you, my sister's 2 kids coming home from college, they both had COVID, we know that. But neither my sister nor her husband have. So what's the advice?
Yeah, so that if you had it and you were sick, we think you have ridded it from your body after 10 days, that you can't be infected. Even if you do a PCR test or PRC, whichever, if you did the test and it was positive, we don't think that is an infected, it's just left there. Your body has taken care of it. So you don't continue to be an asymptomatic carrier if you've had the infection. That's just not in general. I'm not going to say it can't happen, but we got to get people back into society, and that's what the data would show. We're not trying to make this up. You're okay to go back to work. We don't think you're an asymptomatic carrier.
Would you still have them wearing a mask? And
I would have them wearing a mask for the same reason they could catch something else, and but they shouldn't be giving it to someone.
okay.
Yep.
Okay. Can you speak to your plan, if there is any, on the distributing of the COVID vaccine when it comes available?
You know, really the quick answer to that, to be real honest, is no.
And the reason for that is that what we understand is that the federal government is in control with both Pfizer and Moderna, that they are the ones supporting this, and they are going to make the distributions to the departments of health, at least what.
So state by state.
What we'd understand is that's where it will come in Ohio. Ohio is in the process, again, I'm going to say what I understand, and I've been on a couple phone calls, that once the state gets it, then the state will decide who are the individuals to get it. And I think the general feeling is it's going to be the same ones that are high risk, elderly, and healthcare workers, of who would be, and what's a healthcare worker. I'm not a frontline healthcare worker, is going to be frontline, but that is a decision that's being made, and I know the Ohio Hospital Association is involved in that, the State Medical Association, who would be the individuals that should receive this. So we will get some. One of the problems with the Pfizer vaccine is that it has to be stored at a minus 70 degrees. And in general, nobody has freezers that, we don't have the reason to keep a freezer that low. It's usually in the really big places, and so that's going to be part of how the distribution is going to occur.
And that's why I said no. I know
Yeah.
that's a frustrating answer, but all kinds of talk. But until we know, how do you keep something at 70 degrees below zero? How many are we going to get? When? What is the ultimate priority list? Once we start to know that stuff, then we will be talking to the community about what to expect.
So many of us who volunteer are anxiously wondering if there's anything at all we can do for the associates to help with this heavy load that they are carrying for the entire community.
Yeah, that's such a nice question. Thank you. A couple things. One is, if you're interested, you can check online. We're going to try and put together a big day of thank you for our workers. And it's a little unclear exactly what that's going to look like, but there's going to be an opportunity. If you want to donate some money to that, that'd be great. I think the other thing that's really powerful is thank you notes. We can put stuff on our website we call the core. I've found that our staff, Bill and I walk around a lot, and the power of looking someone in the eye and saying thank you is really powerful. And I can tell you caregivers are deeply touched when they get letters, notes, whatever you want to call them, from individuals acknowledging what they do. And as you might expect, Bill and I this morning ran into a young woman. She'd worked 17 straight days and couldn't have been more upbeat. She said, I'm doing this because it's my job and because it's important. And when I've had enough, my boss knows I'll tell her. But until then, I'm pretty good. And this is what I do. That's pretty heartwarming. And how many people did we run into today that said, well, I'm normally on the 6th floor, but I've signed up to help here on on 4th floor, or whatever it might be. We've had volunteers often offer to help in any way they can. We've had retired nurses offer to help. So the community is really reaching out to try and say, how can we help this go better? And I love that question. So those are the two ideas I have. Bill, I don't know if you have anything.
No, I think that's absolutely right.
I was thinking about saying a bottle of gin, but that probably isn't the right answer.
Yeah, but it may kill COVID. I don't know. They say Listerine does. So
Let's
I
give it
don't
a
know.
try then.
Yeah, everybody be happy. The other, what Scott said is exactly right. The other, and I was just down in the emergency room, and I asked, okay, we're going to be on TV. What would you say, somewhat along those lines? Please stay home at Thanksgiving. Okay, now what's that mean?
Overwhelmingly, that's what we're hearing.
Is that, we're in 2 weeks. We could be overwhelmed. I mean, we saw that 4th of July. We've seen it after Labor Day. We've got kids coming home that's already been asked, maybe bringing things home. And so if Dr. Ratnasamy talked to, we have incident command every day. The last thing he said about 4:30 was, if you don't know who you're going to be with, keep the groups as small as you can. We're all really concerned about that. We've got a big holiday season afterwards too. And I think for healthcare, to see somebody that comes in, you got to remember, I mean, we got nurses and a lot of other people that got kids at home that are putting their lives on the front line. And it's a little bit frustrating when somebody comes in pretty cavalier, didn't believe any of this. This is a big hoax. This is no big deal. And now we're putting you on a ventilator. And so I would say to the community, the more you can follow what is accepted scientifically about what best practices are is really important. And then I feel better as a doctor that I'm trying to take care of you. But that's psychological, and I think the two things are met. But
Bill, to me it goes a little beyond being psychological. The individual that says, I don't care if I get it, okay, that's your choice. The problem is you can be a super spreader.
Yep.
And you can infect other people unknowingly. I don't think very many people would want to do that. But given the fact we don't have a vaccine, given the fact we know that for older people and people with other comorbidities, this can be very, very dangerous. that's not great. So,
Right, right.
How are we on testing supplies?
well, how are we on testing supplies? We continue to struggle with that. And it's not that we have the capability in our lab. It's difficult to get the reagents we need and the quantities we need from the manufacturers. So we still rely on some outside labs to help us. We are getting closer and closer to being self-sufficient. That's my quick answer. What would you say?
No, I would say that too, and we're able to check somebody comes into the emergency room. One thing about both our laboratory and our infectious disease people is that they have been very cognizant of what the need is, but also to have very accurate and reliable. I mean, we could be doing testing, and there's places where that could be helpful, where it's 70% accurate. What do you tell the other 30%, and et cetera? So we've tried to be as accurate false positives, false negatives as what we can. With that being said, there are some things on the horizon. We're hoping that we're going to be able to do that. It would make life for all providers much easier if we could be able to do a lot more random testing. I mean, this is what public health would say,
Then we'll
but
start
especially with being able to see that. But right now, if you come into the emergency room, we're able to get a test, and in general, it's very manual, but we're able to turn that around in an hour or two to say what you have.
Yep.
Are we using convalescent plasma, and is there someplace local that people can donate?
So the answer to that would be to talk to the Red Cross. You could call any of the Red Cross. It's done through Toledo. We are using it, our standard regime, and maybe Scott, we were talking about this before. Standard regime of what our treatment is if somebody needs to be in the hospital. We've already talked about those criteria. In general, those individuals will be treated with a steroid because of the problem of what your body can do. They're going to be treated with remdesivir. I don't think it's controversial, but the World Health Organization last week came out and said that they didn't have studies to say that it's that effective, and is it worth it in general. We talked about that with our medical staff. The feeling is, and as Scott pointed out to me, I've said there's no medicine that doesn't have a side effect. We don't see side effects with this to any except unless you have a reaction. Our physicians feel, again, this is anecdotal. These aren't these blind studies that we're talking about if we talk about the vaccine, but that it is theoretically worthwhile, that we would continue to do that, and we are giving plasma. The last time I had checked, we'd given over 100 units to some 65 people or something like that. And so we would ask people, if you are interested in donating, the Red Cross will be glad to help you with that, and we are using the plasma.
How accurate is a throat swab when being tested for COVID-19?
So if it's done properly, and we have trained everyone how to do it, it's not that easy. In fact, I was reading something today. Well, Scott, you and I had done it at the same time. It seems like it's a lot longer than what it looks like when you pull it out. It goes down in, you twirl it 3 times, and then you let it sit there for so many seconds. And so if it's done properly, and with the testing that we're looking at, I would say it's 90% accurate. And it's not because of the nasal swab, it's because of how much antigen or virus you have of the test picking it up. Is that fair about how long they?
Yeah,
seemed
it
like
wasn't
it was
great.
in there a long time to me, but
We survived it, but yeah, you're right.
How many floors are designated for COVID at BBH?
we're using all of our floors, but
Yeah.
we're not using the whole floor.
Well, not the third, OB, no.
Yeah, that's a good point.
But we have COVID patients everywhere else. 4th floor is all COVID right now. 1 wing and 5 is all COVID, I
Yeah,
believe.
getting there, and 6.
And 6. And then we have some in the ICU and CCU, so yeah.
All vents, anybody on a ventilator would be in the intensive care unit. And that would be our plan of what we're doing. that what we're trying to get to is negative pressure rooms. The south end of the hospital.
Explain it,
is either-
make sure everybody knows what that means.
Negative pressure means we're sucking out the air generally, and we're not having it reflow, so that we can extract it and get the virus that would be in the air out of the air.
You know, I talk about this a lot, and this is an amateur's point of view. I'll say that right up front. But one of the reasons why negative air comes up in my mind is being outside, to me, by everything I've been able to read, is a lot safer than being inside. Because with even a breeze, if there's virus there, it's getting moved around and also dissipated more quickly. So I do think being outside whenever possible is safer than being inside. And the windier, the better.
Yep, absolutely true.
Is 6 feet really enough space to keep us safe?
Everything is a risk. Everything you try to balance. So, in general, 6 feet is plenty. The air that I'm breathing, I'm just talking about breathing, probably gets out about 3 feet. Then it starts to really dissipate. If you've ever seen somebody with a violent sneeze, though, droplets go a long way. There's some impressive things on the internet that you can go out and look. But in general, it's going to get down to a low level. Now that's, again, someone that's not sneezing, coughing, singing, and doing
Yelling.
things like that, yelling. Yeah, because the force is going to send this out. There's still, it's not controversial. We feel in general this is still spread by droplets, and droplets don't go that far. The aerosolization, in other words, the virus is just in the air, not on a droplet of sputum or things like that, can go out, but it's not felt to be, it's not that effective for the virus. The virus wants you to sneeze. The virus has evolved to have to be in the sputum to be able to be, it's because it's got to reproduce itself. So the most effective way is by, again, me sneezing in a droplet form.
Can patients go to Bluffton Hospital for non-COVID health issues? Is there less of a wait time?
Well, the way the emergency room was last night, I'm sure there was, because I think Bluffton saw about 15 people. In general, yes, we've got physicians around the clock. There isn't anything that can't be taken care of in Bluffton Hospital. We may not admit someone there because of ventilators and things like that. But sure, going to Bluffton is a great place to go. They're able to do CT scans, they're able to get x-rays, they can get labs. Turnaround time is really good, and plus they're really nice people down there.
Yeah, I think Bluffton's a great alternative, and one that particularly people on the south side of town could avail themselves of more often if they're comfortable with that.
Do I have to wear a mask at all BDHS locations?
Yes. Quick answer. Trying to think where you
Just
wouldn't
leave it
wear a
right at
mask.
that, yes.
Yeah. The one thing that, it's not just here, interesting study from Mayo Clinic, our friends, is that now we're talking, Jen, we're talking to our people that work here, but this is to everybody. They found that they've got 1,000 people off. Of those 1,000, they felt that 93% of them got it outside work. So I'm not picking this up at work getting COVID. We're not aware here, somebody asked me that question, of anybody ever getting COVID who was in the hospital from being in the hospital. They came in with it. Okay, so this is going on out in the community. And then the thing that I thought was most interesting was the individuals that are getting COVID in the hospital, they're getting it in the break room.
Yep, lunchrooms and break rooms.
And that's because just, okay, break room, I get to shut the door, I can take off my mask, put my feet up, not allowed to have a cigarette, but we don't have any smokers anyhow. But break rooms are where people are getting things. And so it was interesting when Scott and I made rounds today. Yeah, that's kind of where we try to relax. Well, you relax with a mask on. That would be the rule.
And people say, well, I got to eat. The response I heard from one physician is, COVID doesn't take lunch breaks. Well, it's kind of a funny way of saying it, but those are probably danger points.
Does your air system have UV light for disinfection? Do you have a UV robot?
We have 2 UV robots that we use, and they're, what I understand, that's not why we have them. We use them for bacteria, especially for C. difficile, of the reason that we had helped them to clean the rooms. But we do use UV light, and we use it in surgery that we go down to disinfect.
You know, that raises another issue that is an expansion on the question, but so far, our clinical quality data around people getting infections at Blanchard Valley, it's incredibly good. It's the best we've ever had, and really work hard at that. So one of the questions I get asked in the community is, it's safe to come to the hospital? When you've got UV lights, when you've got the kind of disinfecting we do, the data would say it's extremely safe.
Yeah, I think it's really safe to be, and I think our associates would say that too. I mean, I had 4 kids. There's no question in my mind, with them all going to school and what they would be doing, and with Kay, that I would have been more likely to pick up something at home or give them there than picking up something here at the hospital, because we're all in mode to take care of ourselves in masks.
Are you planning on transferring all OB patients to Bluffton for their care and deliveries?
No.
I agree, no.
Now, the qualifier there is, that would be an absolute last resort. In fact, I can't imagine a scenario where that would happen. So I'll just stop there. The likelihood of that would be extremely low.
And the only reason we would do that is if we wanted to take over all the OB beds and turn them into COVID beds.
Yeah, and that's it. Not only is that highly unlikely, then you've got to de-license some beds with the state, and I think there would be an issue with that.
Yeah, neonatal beds.
Is it
and that's where-
impossible? No. Is it highly unlikely? Yes.
Sorry, just looking.
Come
for
on,
comments.
stick with it.
Is there a local consensus on good outpatient treatment of high-risk people presenting with symptoms or diagnosed with COVID?
So we are working on that, and I don't know that that we have it's not a consensus yet. We're trying to gather data as to what's going on. So this is what we are advising, and this is what the emergency room, and I think we're getting a little closer as to what individuals would be treated with. Now, the question was high risk. I'm going to just talk about in general somebody that would go home with a diagnosis of COVID. It's probably worthwhile, it's certainly safe. Again, there's always this risk benefit of taking vitamin C, vitamin D, zinc. I read somewhere where Listerine, or I'll use that would be a trade name, obviously, but a mouthwash kills a lot of viruses, worthwhile. So those things make sense. The Pepsid, there's some theoretical of taking a drug like that may be commonsensical too. I'll just say anecdotally, myself, I've never taken a vitamin in my life, except I think Mom made me take vitamin D. I hated that stuff. It smelled bad too.
Well, you survived.
Yeah, I did survive it. But I started to take a multiple vitamin. I think that makes sense to do, and maybe it just makes me feel better. If you are on steroids, you ought to continue those. That is important. Now, there is controversy about what should be used as far as steroids: prednisone, decadron, dexamethasone, those kind of things. In general, the feeling is that we wouldn't start that as an outpatient because you're not sick enough to need them, and that's a big detailed thing. Dr. Ratnasamy talked to the medical staff. The other thing that really is important about that question is there is a new monoclonal antibody out that we're working through the process. We have a few doses for someone that is high risk, that could go home, that are, let's say, mildly or moderately severe symptoms, but to keep them from going into the hospital, there is this monoclonal antibody. There's the monoclonal, and monoclonal meaning it's one antibody that seems to attack that. It's got a couple
That being the virus.
the virus.
Okay.
And this is what President Trump got. And now the FDA has released it as emergency. We're working through the process of how we're going to screen those people, make sure they meet the criteria. It's only for outpatient. And so there will be more to come about that, hopefully fairly soon, since we're able to get some of that medication.
That's pretty new, so.
That's really new, and that's maybe a game changer, because the FDA feels pretty comfortable, and obviously, if you heard the president talk about it, he thinks that really helped him, which I think he was right.
If risk is being seen in break rooms, is it safe to eat in restaurants?
That is probably the toughest question that there is, because of all, there's a lot of people that eat in restaurants. So what my experience has been, I feel safe going to the restaurants around here, because they've tried to separate. If you want to go in with your family, I think that the business really understand that. I mean, everybody's had a mask on that served me. You obviously have to take your mask off to be able to eat, but if you know the people that are with you, and if the other tables are 6 feet, I feel reasonably concerned. Now, nobody asked me about a bar. That's a little bit different.
That's
And
a lot
I don't
different.
know, because I don't see the social distancing, and I don't see the masks of the pictures, but
You
maybe,
hang out in
maybe
bars
that's
a lot,
not fair.
don't you?
Yeah, well, I'm getting pretty old, Scott.
Okay.
I got a family now.
Let me kick in on this too. And I want to be careful, because I do not, for 1 second, want to come off as being critical of what's going on in this place. But you poke my head in a break room, and there were 5 people. They were not distanced. 4 had a mask on, 1 didn't. I'm assuming at some point, if you eat, then nobody has a mask on. One of the things about restaurants is they're doing a pretty good job of keeping you separated. Maybe 4 at a table, that's it. And I think you can be 5-6 feet apart. I'm not sure we're following those same guidelines as religiously as we could in our break rooms. And we'll be talking to the organization about that as we're learning more about it, and I think we can get better. So to me, that would be the differentiator in how I would answer it.
Can you talk about our critical care pulmonary physicians? Is this a fairly high level of care?
We are extremely, I think, fortunate to have 4 individuals that are board certified intensivists, pulmonologists, meaning that they're lung specialists, and that's been present for the last couple of years or so. We were really fortunate when COVID started, because of how they had set up their schedules, that they were able to overlap, and yesterday we had 3 of them working. So from a capacity, we are really extremely lucky. In general, that's not something that you're going to find in our size of a hospital, to have that size of a group.
Really true.
And they are good people that know what they're doing, so the competency is there too. The other thing why that makes us so helpful is they're able to work with our hospitalists, so that we as long as we don't get individuals sick, is that we really have the medical capacity to take care of people in the hospital. And as Scott mentioned, and I think I mentioned too, we reached out to Bowling Green, to Wood County Hospital, and said if you would need some help. And so that was early on in the COVID crisis, arrangements we made that kept everybody busy, and I think it's probably been a real positive for Bowling Green also.
And for Bluffton too. So,
Yeah.
I mean, this is a really great group of people. We are really fortunate, and I think our patients get great care as a result of it.
Right.
If someone thinks they have COVID and needs to go to the ER, should they call first? Is there a separate entrance?
There is a call. Well, first, if they're going to get a test, they need to go through their primary care doctor, and then they will order the test and get it done. If they think that they're sick, then they just go to the emergency room, and one of the first questions, and I've been down there, what's the problem? We triage them outside before they ever get in the emergency room. In general, we've designated the waiting room for those individuals that are sick with an infection, especially COVID, so we segregate them right away, and then they would be taken back as a potential COVID patient. But you'd still come through the same entrance.
But I'd also emphasize, as a little bit of that question could be interpreted a couple different ways. It's really important, to the extent you can, to let your doctor know what's going on, and let them order the test for you. They know who you are. They know your background. Sometimes that may not be the appropriate thing to do.
Yeah, that's another. Scott makes some really good points once in a while. Okay, so we're gonna get. He's got at least 2 points.
Not very often, but once in a while.
Our concern, and this is as a healthcare, and I think all physicians, we don't want anybody getting lost. And so it's really important that your primary care physician knows that. If you were to leave our emergency room, do I understand what my follow-up is going to be? We're making calls from the emergency room to make sure you've gotten in. But again, this is somewhat complicated. It takes time to educate people. So the primary care physician being involved as much as we can. We're trying to do, as a medical community, telehealth, keeping track of people, but we don't want people getting lost, especially those individuals that may have behavioral or mental health issues. They can get confused. Someone with mild dementia can get confused. And that's a real concern, because we don't have enough home health people. We are over capacity there. And so that primary care is, again, really important.
When is the next Facebook Live?
I think we have it scheduled for December the 3rd, correct?
At noon.
At noon?
Yeah.
Okay, so we'll be back up close and personal on December the 3rd. Hopefully we'll have some good news, but I'd like to reemphasize these next few days are really going to be important. Please wear your masks, stay 6 feet apart, don't be hanging out with people you don't know where they've been. Wash your hands a lot, use hand sanitizer. Those are the best defense mechanisms we have.
That's it. Yep.
Are we done?
Yeah.
Well, good, because we've taken an hour, which is
Time went fast.
pretty close to an hour anyway. I guess as we close, I don't know how many are tuned in. We'll learn that when we close here, but hopefully this continues to be useful time. Bill and I are more than happy to do this. We are the ones that really pushed to have this one done quickly tonight, because the environment in our community has changed so much so quickly. So we want you to be aware, and we want you to be safe, and we want you to have as nice a holiday as you can, given the fact that it's probably not going to be perfect, and that we think we're in this for a period of time now. I don't think this is going to be over anytime real soon. So again, thank you for tuning in. Bill, any last
No,
words?
if you have questions, though, send them in, and we'll make sure that we try to answer those, especially the questions about the vaccines. Maybe we'll have a little more information in.
Yeah, as the days go by, as we've said all along, you kind of never know what you're going to be reporting on, and certainly for us to have our inpatient census of COVID patients go from 29 to 51 in less than 2 days was a bit of a surprise. So I guess December 3rd will be another surprise. And until then, we appreciate your attention. If you have questions, let us know, and we'll see you again soon. Thank you.